The topic is mitral stenosis. There is a reduction in the orifice of the mitral valve. The normal orifice, cross-section of the normal orifice of mitral valve is around 4 to 6 centimeters square, and reduction of the orifice to around 1 centimeter square is considered critical. In mitral stenosis, the mitral valve does not open adequately during a diastole, and in between the left atrium and ventricle there is a diastolic pressure gradient, and this diastolic pressure gradient depends on factors like the cardiac output, the heart rate, and the area of the valve. The left atrium starts to dilate because of an increase in the left atrial pressure, and this dilation is compensatory. The increased left atrial pressure is then transmitted to the pulmonary system and leading to pulmonary congestion. Later on, there is development of pulmonary vasoconstriction, and there is an increase in PVR and development of pulmonary hypertension, and the right ventricle must develop enough force to move the blood across through this resistance in the pulmonary system, and also due to the mitral stenosis, there is development of right ventricular hypertrophy and eventually right-sided heart failure. Also, due to the increase in the left atrial pressure and subsequent left atrial enlargement and the left atrial remodeling, there is atrial fibrillation and also clot formation in the left atrium. They could be a exertional dyspnea, and then orthopnea, and then the PND, and then acute pulmonary edema that could develop after exertion, and there could be systemic embolus, and folks may have hemoptysis, and hemoptysis due to persistent pulmonary hypertension, in hoarseness as a result of the impingement of the left recurrent laryngeal nerve by the enlarged left atrium. And of course, right-sided failure could be presenting as edema, anorexia, ascites, fatigue. Folks would also at times present with infective endocarditis and their symptoms and signs, and then sometimes present with chest pain or palpitations as a result of atrial fibrillation. Then there would be accentuation of S1, an opening snap, and then a murmur, mid-diastolic rumble, low-pitch murmur, heard best at the apex, and then thing about the accentuation of S1 would be that more mobile the leaflets are and more flexible they are, more the accentuation. And the opening snap is basically when the high left atrial filling pressure forces the stenotic valve open in diastole. That leads to an opening snap. And shorter the interval, the A to OS interval, more severe the stenosis would be. And regarding the mid-diastolic rumble, a low-pitch murmur that was that is heard at the apex in mitral stenosis. The thing about this murmur is that longer the duration, the more severe this murmur, the more severe the condition would be. And then in situations where there is involvement of the right heart, one could see an elevation in JVP, and pulmonary hypertension would basically be indicated by a loud P2 and then a right ventricular heave, a palpable right ventricular heave will be present at the left sternal border, and then a Graham-Steele's murmur could be present, which is a soft early diastolic decrescendo murmur, which is caused by a pulmonary regurgitation and would be heard along the left sternal border, and often this is confused with the aortic regurgitation. And then a TR murmur could be present. And folks with normal sinus rhythm, a prominent jugular A wave is present. X-rays would show the straightening of the left cardiac border due to the dilated left atrial appendage, and then pulmonary congestion and edema. The curly B lines could be present, and the prominence of the pulmonary arteries, or calcification of the mitral valve or the annulus, along with the calcification of the mitral valve could be there, and there could be enlargement of the right ventricle and the right atrium. At times there is a double density along the right heart border as a result of left atrial enlargement, and when there is a right ventricular enlargement as a result of pulmonary hypertension, the lateral view would show loss of retrosternal airspace. ECG would help demonstrate the right ventricular hypertrophy, the atrial fibrillation, and of course there would be a P mitrale and a broad notched P wave with duration and lead 2 greater than 0.12 seconds, and as a result of left atrial enlargement. Echocardiography, TTE and TEE are helpful, and exercise testing with echo is often done. And TTE is basically looking at the etiology for mitral stenosis and looking at the leaflets and to determine if PMBV should be done in a candidate by looking at the leaflets and the apparatus, the subvalvular apparatus, and looking at things like the transmitral gradient and the mitral valve area, and then determination of the right ventricular size and how it's functioning, and then also to have an estimation of a pulmonary artery systolic pressure, and the TEE and TEE would be performed in patients in whom TTE would be suboptimal, and looking at things like in patients with mitral stenosis, looking at the hemodynamics in those patients and how the mitral valve morphology would be, and also to look at the clot if it's there, and then and also if there is a mitral regurgitation uh, present, then in those situations looking for this condition in candidates who are being considered for PMBV, to look at whether the MR is severe and what's the situation of the MR in this patient group. And in situations where there is some kind of ambiguity arising from clinical findings, signs, symptoms, and Doppler findings, there's ambiguity arising from looking at these things, then one can take the help of exercise testing with echo, helping in clarifying um, things like the transmitral gradient and the pulmonary artery pressure with exercise to have a better assessment. Catheterization is another tool that is often utilized to um, look at situations in which the severity of pulmonary hypertension is actually out of proportion to the severity of mitral stenosis, as determined by the non-invasive methods. What exactly the reason could be in such a situation, and also when the clinical and the echocardiographic assessment are actually discordant, and in those situations to look at the severity of the mitral stenosis. Also, catheterization is often utilized, and then the severity of mitral stenosis basically is in situations where the valve area is less than 1 centimeter square, the pulmonary artery systolic pressure is greater than 50 mmHg, and the mean gradient is greater than 10 mmHg. And also there is an anterior movement of the posterior mitral valve leaflets during diastole. Often there is a fusion of commissures, and the posterior leaflet tends to move anteriorly with the anterior leaflet rather than its usual posterior direction during a diastole. And echocardiography would pretty much demonstrate that. There are several etiologies associated with mitral stenosis, and rheumatic fever, a very common cause in underdeveloped countries, and in the descending order of occurrence, um, it's the mitral, aortic, tricuspid, and the pulmonary valves that are affected. And several other causes include rheumatoid arthritis, SLE, and congenital causes, and then mitral annular calcification, and often when there is an ASD with acquired mitral stenosis called as Lutembacher syndrome,